All right, everyone. Thanks for joining us tonight. I know it's cold in some parts of the U.S. right now, so thank you for joining us again. So a little introduction.
I'm Lori Cochran. I'm a speech pathologist, and I work in Fort Worth at Cook Children's Medical Center here. And I don't see as many AAC kids as I used to, but currently still kind of support our AAC program through a lot of administrative things like mentoring others and making sure all our clinics have the right equipment and that it's all working and things like that. And still get to treat a kiddo here and there with a device.
And my name is Teresa Jones. I also work in Fort Worth. I see a lot of AAC. I definitely think this is one of my passion areas. I love working with medically complex kids or kids who are just finding their voice with AAC. So it's definitely one of my favorite things to do. But we want to learn a little bit about you. Do you have that poll, Allison?
Sure thing. Everything's launched on your screen there. So we're going to let that run for a few seconds and we'll see who's in our audience tonight.
So it definitely looks like we have a lot of OTs. So thanks for joining us, all our OTs. And I see some other areas. And we have some speech path. Hello, other speechies. Great. So we do have one other question for the group. If you want to put this in the question box, is who's interacted with the AAC and what systems? So we'd love to hear what systems maybe you already have some experience with. And then you'll see also in the poll section if you have any past experiences with AAC. Okay, so it looks like majority of the crowd does have some experience. We got some touch chat and LAMP. That's great. We'll be talking about those today as well. Awesome.
Okay, so let's talk through what we're going to cover today. We want to talk about the different levels of technology when we talk about alternative and augmentative communication. There's such a wide variety of options out there, and kids coming to you guys that may have devices on a tablet, they may have pictures, they may have all sorts of different things. And so we're going to talk through kind of what each of those are and kind of all the different options that are out there. We also want to talk about different access methods. We know that not every child can access a touch screen by pointing to it and touching it with their isolated index finger. And so we have a lot of different options for kids that cannot do that. And so those kids deserve to communicate as well. And so we're going to talk about how we get them access to their communication. We're also going to talk about just some basic cueing strategies that we use in speech therapy. We teach parents to use them at home. And so they're excellent things that you guys can use in your sessions as well. And then lastly, we're going to talk about how do you determine which children are good candidates for AAC? And if you come across a child on your caseload that does not use communication, verbal or otherwise, would that be an appropriate referral to speech to look into AAC? So we'll talk through all those things.
So let's look into what exactly AAC is. So the acronym Alternative Augmentative Communication, but since over 2 million people use AAC, let's dive into exactly what it is. AAC is really all the ways we communicate without talking and is comprised of 2 different modes of communication. We have aided and unaided. Unaided modes of communication are going to be things that include non-spoken means of communication like body language, facial expressions, and gestures. Aided modes of communication include modes that need external support. So I find this is usually what people think of when it comes to AAC. So those are things, texting includes this area, and of course communication devices, which is what most of our talk is going to be about. We'll mostly be focusing on anywhere from what we'll go into is light tech, mid tech, and high tech.
Okay, so we're going to, just like Teresa said, start at the basics where there's no tech involved, and we'll work our way up. So a lot of these no tech types of alternative communication are those unaided types. So sign language, gestures that we all use every day. Sometimes kids come up with their own gestures because they know they don't have a way to communicate a particular idea or something that they're asking for, and they've not been taught a specific sign for that. And so they're really creative and clever, and they come up with things all on their own, and their parents are so smart to figure out that, gosh, they do that same thing every time they want that same item. So they figure it out all on their own. Body language and facial expressions, these are things that we all do every day to supplement our communication that we do verbally. And so it can be a great tool for our kiddos who maybe don't have a verbal form of communication to fall back on and support them as well. We'll move on to light and low tech. And so this is where we start getting into aided forms of support. A lot of light and low tech communication systems are a lot of times they're paper made. Some therapists out there or some mom or parent has put in a lot of hours of finding pictures, taking pictures, printing, laminating, making something like what you see here on the picture board or on the slide with picture boards and things like that. It does not have to be this intensive, however, but these were some good examples of ones that are a little bit more robust and contain a few more words. So these similar things here are not to be confused with visual supports. We a lot of times in our therapies use visual schedules or other visual supports that maybe support regulation or behavior management and things like that. Now, those sorts of visuals can kind of serve a dual purpose and be also used for communication. And because having successful communication does help a lot of times with regulation and behavior management and things like that. However, the things that we're going to be talking about today, just want to make clear that they are maybe built for the purposes of communication rather than some of those other reasons we use visual, like pictures like these. With this type of AAC, it can be really easy to get stuck in requesting. I think that is a reason for communication that many children need and they start off with because it's very easy to teach children and kind of reward them for that. You've asked for this item, you've successfully communicated it, I've understood it, and therefore you've received it. And that's really motivating for children. And so, but as a general rule, we want, we communicate about all sorts of things, not just what we want in life. And so it's really easy to kind of get stuck in requesting, but it's important to remember to work outside of that and go beyond requesting. Like I talked about, these can be very labor intensive to create and very cumbersome, especially if you have a child that needs a lot of words or grows to need a lot of words. So they can be as simple as a sentence strip, or it could be, these picture books with lots and lots of pictures. There is also, I don't know if you're familiar with PECS or have heard that term before, that is the picture exchange communication system. And that is a very structured, outlined way that you can be trained in to utilize these pictures, primarily for requesting, but also other things later down the line. And so many speech therapists are trained in that, but you absolutely do not have to be trained in that to use this form of AAC. Even just a simple choice board for a child that just needs a simple choice in an activity. Another thing I don't have a picture of here, but that this level of AAC is really helpful for is just a functional communication board. So, for someone who is maybe, just received a trach or is impatient and can't communicate verbally for a temporary time, something really quick that is just one board that has a few simple things on it they can point to, that can be, quickly made up for that and be very useful in a specific instance. That is this light or low tech form of AAC. So lots of options here at this level, but let's move on to mid-tech and talk through. So here's where we get a little bit more technologies involved. Usually these sorts of, this sort of equipment has batteries involved. Usually they're just going to be a replaceable battery that you've got to change out. And there's also voice recording usually associated with this level. Usually it is just your digital voice. So you will click a button, record a phrase that you say yourself, or the parent or whoever. And when the child activates a button, it will play that recording for you. There are some, so you'll see kind of the blue and green buttons. Those are just simple single buttons. So they record a single message and that is it. The 4 button row at the bottom, that has, you can record 4 different messages, one for each button. And then a lot of times they'll have levels. So say I want to do one activity and I need 4 words for that activity, but then in the same session, I'm going to do another activity. I need 4 new words. I can program it so it can hold those words and I can easily switch back and forth between those. So something simple like that. Usually these, this level of AAC is kind of from maybe one button to maybe like a 16 choice board. The blue one there in the middle with the 4 choices has actually interchangeable faceplates that you can pull out. And maybe I have a kiddo, at 8 o'clock that needs a 4 choice board, and then at 9 o'clock we need a 16 choice board. So I can switch those out easily with the laminated overlays and just pop it in and out. And have the recordings kind of set and switch between them. But so there is some flexibility, and we are starting to build to greater vocabulary at this level. But you can see we're not quite at the level where we're going to get to at high tech. And then with this level, many times the focus is you're focusing on core words that you would be able to use across many different activities. For example, the words that are on there right there, there's more, there's stop, that's like again or something, and go. So those are words we can use across many different activities, and you wouldn't have to switch them so often. So moving on to high tech now, here is where we really get to the most robust vocabulary systems. These devices are usually tablet based, so they've got the rechargeable battery that you can plug it in every night and charge it up. These also do usually have the option to record a voice if you so chose, but typically they are relying on a synthesized voice. So I'm hitting the buttons and the computer is speaking the voice. And they're great. You can select, if you have a small boy, you can choose a young boy voice. If you have an older girl, you can choose an older girl voice, and everywhere in between you can tweak the sound settings so that it really fits the child and becomes their voice. They have thousands of words available in the various vocabulary programs Teresa's going to go into in a little bit, but they're very customizable. So you can see the one on the top right only has like 8 rows. But that device also can be programmed to look like the others, where there's, an entire grid of vocabulary. So these devices are really nice because they can grow with the child as their language needs grow. They can also change different features that may be needed to help the child access their device. So changing the size or color of the buttons, or how many, are on the page if you want to hide some of the words on the page so that it's not too distracting for the child while they're still learning new words. There's also, we're going to get into different access types. So this is if you have a child that needs to access their communication in a way other than kind of what we saw earlier, just hitting a button. you would kind of have to start at this level with high tech, because these are the devices that allow for those other access tools we'll talk about. And so this high tech level is really designed to meet the needs of many different types of communicators. So you absolutely don't have to start with low tech or mid tech if you feel like there's a high tech device that is appropriate for the child at this moment and will continue to grow with them.
So we're going to dive into that specific area of high tech, which is AAC SGD. That SGD piece stands for speech generating device. We're talking through the main 4, but if you were to ever look on an iPad for any AAC system, there are thousands to choose from. So I'm going to go through the main 4 and kind of talk about the differences between them, just so that you're familiar. So these communication devices are considered durable medical equipment and may be covered by a lot of insurance plans, just like a wheelchair or any other DME. And a lot of the times, especially the devices that you see here, are on what we call a dedicated device, where the sole purpose of that device is only for communication. So they usually don't have access to the games or watching YouTube on there. We want to make sure it's easy access for them to communicate and doesn't have any distractions on the device. And when we look at all of these devices, usually that's chosen by an SLP that is doing a really holistic evaluation to find the best fitting one for the patient, not for the one that the SLP knows the best. So we always try to make sure we find the one that fits the patient and not something that we're just super familiar with. So the first one we're going to look at is LAMP. That's really popular. It can come on iPads, specific dedicated devices. It is made by Print-Q-Romich, which is also merged with Saltillo, which does touch chat. And it stands for language acquisition through motor planning. And it's divided semantically, or just how we use language. So it's not going to be divided up in categories. And so it's leaning on that motor learning principle, where one word is only presented one time and it has the same motor plan to get to that word every single time. And so it helps reduce that navigation workload by having this feature, so that the individual doesn't have to scan for the button, read words in order to get to what they want to communicate. And I know it's probably small on your screen, but you'll have it on your handouts. You'll notice that the majority of these systems are color coded, and there's a reason behind that. It's usually the parts of speech that they are color coded by. So like pronouns are yellow, actions are green. And this also helps with them trying to get to the right buttons in order to make phrases. And then the next one we're going to look at is going to be TD Snap, which is made by Tobii Dynavox. They also have a ton of options on their different devices. So it's available on an iPad, it's available on their dedicated devices, different sizes, different weights, just like all the other systems you see here. So that's something we also want to consider when picking out a device for a child, is weight, how they can carry it, vision, all of those areas. But something different about TD Snap is what you see on your screen. You notice there's not a ton of buttons on there. They go all the way up to smaller buttons like LAMP has. And they also just introduced a motor plan option, which is also similar to LAMP, but looks a little different. I think the biggest difference between, if we're comparing our first two here, between LAMP and the TD Snap, is how they're organized. So the TD Snap, the majority of their page sets are going to be organized by categories. So all your foods are going to be in one place, all your colors are in one place, all your toys are in one place, all your actions are in the same place. As opposed to LAMP, it's organized by how we would use the word. So like go is going to be in one place, and then want is going to be in another place. But we've really noticed, like over the years, that a lot of companies are adopting the same configuration as the PRC color coding. So you'll also see there's yellow, there's green, there's orange. So there's going to be a lot of similarities across our systems in regards to that, which is really nice, because then our kids kind of can go across systems if they ever grew to needing a different system. And then I did see someone mention touch chat, that they have some experience there with that one. It's also sometimes called word power. It's developed by Saltillo, or now PRC Saltillo, since they've merged. Buttons are also color-coded by parts of speech. It also is robust language like R2 that can grow with the patient. And they can start smaller buttons just like the TD Snap can. So less buttons presented, larger buttons, something that they can grow with. So that also offers that option as well. Organized by categories as opposed to LAMP, that's done semantically. So it's similar, touch chat is similar to TD Snap in that regard, that it is organized by those categories. And that one major difference is that it's not every button will return to the home page. Something I forgot to mention about LAMP is the motor planning piece. If you're trying to go to the word go, you go in the folder, you hit the green button go, it then returns back to the home page so that it's the exact same motor plan every single time. Touch chat, not every single button does that. So you go in, you hit eat, and it will not go back to the home page. It will stay in that folder so they can access the vocabulary related to eat. Also, something different is you may hit a button and then some of the other buttons might change, so then it would make sense if they were building sentence structures. So it's a little more dynamic display in regards to that. And another thing is that you'll notice some of the buttons do not have pictures there. So it may need a little more literary skills to have this system. And lastly, a really, really popular one, we see a lot of kids come in with this system because it's one of the most downloaded ones on the iPad App Store. They'll come to us with this as their first system, but one of the things we notice is that they'll come in, but they're not on the robust language or the core vocabulary option under Proloquo. Often it comes in with items that they're going to request for that are really motivating, and that's usually when we get these devices coming to us. And then we want to move them as quickly as possible to that robust language so then it can grow with them. It is also organized based on categories and needs sometimes a little additional motor skills to navigate vocabulary, just because of how many times you need to click to get to a word under their core vocabulary. It sometimes also does need scrolling, and it also has arrows to access additional vocabulary.
Just quickly before you guys move on to the next screen, there was a question in there if you could repeat how LAMP and TD Snap are organized differently.
Absolutely. Let me get back to that. Okay, so LAMP and TD Snap, they're organized differently because LAMP is done semantically, which is how we use language. I can actually show you really quick. I actually have it on my computer, so give me 1 second. I can actually pull it up so you can see the difference. Okay, so this is LAMP. The biggest thing is all the one thing that I think a lot of our families notice is our action words are not all in one folder. So if I go to go, you notice that, oh, I go to school, I go to the library. Are we going? You have some phrase sets in here. When it comes to TD Snap, which I don't have that on my computer currently, it's more so like if I click into it, all my action words are going to be in one folder. All of my description words are going to be in another folder. This system, not as much. So we might have colors in here, but then if I want to describe the size, little is up here. The other thing is that as you notice with little, I clicked on little and it went back to the home screen because that motor plan needs to be the same every single time. And it should be to the point where the patient does not need to truly scan the screen. They should just know, if I go to the middle of the screen in this general area, I can click this and now, oh, I found the green button and it's over here. There it is. So we're really leaning on those motor learning principles, just like with maybe your kids that you might be working with, either childhood apraxia of speech or limb apraxia. We're kind of leaning on those similar motor principles. So it just reduces that navigation load when it comes to using LAMP. And then let me stop sharing that so I can show you all my slides again. And then So that's the major difference. I hope that answered your question. I think that's the hardest piece for when we work with families is the semantically organized versus categorically organized.
And two, I can add that, you know, if you have a child that needs a device like this, they really should be in with a speech pathologist that can kind of help them navigate like which particular device is best for them, because these differences are subtle. The expectation is not for you to leave this course and be able to select a device for a child, but just to kind of be more familiar with that device systems and the variabilities. And then if you do have a child that has a particular device, you know, we encourage you to explore it a little bit more so that you may be more familiar for their sake with their vocabulary setup.
And I do see a question that was related to what I mean semantically. So semantically is how we use language. So I can go back really quick to the LAMP program. It was developed in thinking about how we might use the language and then how we might build the sentence structures. So if I went into come, there's all of our animals. So like come here, you might be talking to the dog. If we might be doing, I find my go is my easiest one to do, is that go to school.
I like
sleep, that. I'm tired.
Oh, sorry, Teresa. Show the do page. I like that one because it's all the action words on the do page are related to the actions you do with your hands. So throw, pass, wave, those are all hand actions. And then if you go back, that's because the picture for do is a hand. And then if you contrast that to like foot actions, it's under the fast page, which is the shoe, the little blue shoe. And those are all the foot actions. So I can hike, I can jump, I can step, I can, you know, more like gross motor, big body actions. And that's because those are related more to your feet or sorry, your feet or your legs. So they are kind of semantically organized, but not quite in the same way that they categorize on other devices, which are kind of more your typical categories, like all the foods are on one page, all the action words, all the, I don't know, locations, all the color words or whatever.
And PRC does offer some courses as well related specifically to LAMP. So if you're really curious about kind of the theory behind that and just want to learn more, they do offer some courses. I just wanted to have this picture here just for y'all to have, just to see even other systems that we're not going to dive into too much. Like this one is PODD, which is done pragmatically. So there's a bunch of folders based on how you would use them. And then there's also scenes that they can use as well. A question we get a lot is why those pictures as opposed to let's take a picture of everything they might have or show a picture of them kicking a ball. They did a study with typically developing preschool children that found that no one identified the picture for the word, the system attached to that picture. So like the picture have, they didn't automatically put it to the word have. And they did this particularly for those core words, those high frequency words, which are usually on the front page of these systems, and more abstract words. Most of these systems will allow you to edit it if you want to put like their picture of their favorite ball, or if they really love Frozen, you can get a picture of Elsa on there. So it does have editing capabilities. And early on in intervention, we really want to determine what our goal of AAC is, like say for the next 3 or 6 months, and that helps us decide what vocabulary we're going to have present and make sure that it gives them the most power in their communication.
Okay, so the question that we said we were going to talk about is who benefits from AAC, and to kind of put a little history behind this, we as a speech field kind of have a history, or had a history of kind of thinking about AAC as like, who would this work for, but who's a candidate? Like, these systems used to be, before technology got so great, used to be very clunky to implement and very expensive. They still are very expensive, but most of the time insurance pays. But they were even more expensive before, and they were, the learning curve for the therapist to use them and for everybody to figure it out was huge learning curve. And so we used to be more selective, for right or wrong, about who would use them and who we would kind of select to kind of go through that process of learning and all of that. But now it's so easy to access this. Everybody has tablets and smartphones and everything in their homes, or can easily get those through insurance. And so the answer now is that everyone can benefit from AAC. Everyone is, has the right to communicate, and so everyone should be able to, work with a therapist, get access to a device, try different things with the help of their therapist, and figure out what works for them so that they can access communication to their greatest ability.
And so one way that we help those kids that want to communicate, to kind of give them that guidance, is by finding different access points. And so this is the piece that we really lean on our OT and our PT friends and our vision specialists, just to kind of help guide us. So we do often consult with them to make sure that we're choosing the best fitting access for the child. Now, what might be the best on paper, or what we evaluate and see, we also lean on what the patient wants to try too. So we're also considering that when we do these evaluations. And of course, the most common one is going to be touch. And usually that's done with an isolated finger to the screen. And if they need additional assistance, we can also implement using a key guard or a touch guide, which are pieces of plastic that go on top of the screen that kind of have a barrier between each button to help them access those buttons more successfully and accurately. Key guards are usually the shape of the buttons, and touch guides usually are even smaller holes in them, usually like an oblong or a circle shape, so the pad of the finger fits in there if they need even more accuracy. Or with our children who have vision impairment, they do have touch guides that have Braille and other ways of using sensation to find the right words on the screen. Another form is eye gaze. So this might be a good choice for our children who do not have full control or any control of their hands or their arms. Maybe reach is hard, or isolating a finger is hard. We often see like maybe a cerebral palsy child might benefit with this, maybe someone who's quadriplegic. And so what it is, it's an additional accessory put onto the device that will follow the patient's eyes. And so usually in that case, we have it mounted on the table or up on the wheelchair mount, and so they can access their vocabulary that way. And then another common one is switch, where you can use switch, not just hands, head switch. I've seen foot switch and knee switches, but in general, they can be activated using different body parts and can be done with scanning. So they can either touch the switch to scan across the screen, one touch goes to the next word and so on, or it can just keep going. It's pretty steady. And then they hit the button when it gets to the word that they want to say. And so that's also part of the evaluation process. We're trying to decide between all these different accesses, and there's even more than we're going over today, such as head point, that we really try to find what the patient wants to do and what our OTs and PTs might recommend as well.
Okay, so let's talk a little bit more in detail. I know I said everybody can use AAC, but kind of looking at like where you might have considerations about what to jump in at, or any of that. So who's benefiting from AAC? Like I said, really any age and any diagnosis. So you might consider different vocabulary systems for different age patients, or different diagnoses and different things, might have different diagnoses might lean you toward thinking maybe they might need a different access system or something like that. But definitely any child or person who wants to communicate but doesn't have a way to communicate, that's a red flag. Let's get them a system. We need to start working on this. Because they need to communicate. They need to have a way, and they maybe don't currently. Also, for those who might need a stepping stone to communicate, so maybe they have some gestures and signs, or maybe they have started using some pictures and some low tech, but maybe they've outgrown that system, or they need to build their vocabulary a bit more. And we also see a lot of times for our kiddos that are, they may be verbal communicators, but maybe very unintelligible because of their diagnosis. Maybe they have a dysarthria, so they have a lot of slurred speech or very unintelligible speech. And maybe only their direct family member or caregiver can understand. But of course they need to communicate at school and in the community and with their peers. And so maybe they need just a stepping stone to help them get to a wider variety of people they can communicate with. It's a myth that, sometimes we hear, oh, that child's too young for AAC. Absolutely not. We start kiddos, 2-year-olds on AAC that are just learning how to, would be learning how to talk, but they need an AAC system instead. Kind of looking at, we also hear a myth of or parents may think, I don't want to start down the road of using a device because I want my child to talk. And we definitely hear that, but the research actually shows that AAC does not get in the way of verbal communication. It supports communication, and that it supports verbal communication. And we do see a lot of children using AAC as that bridge. So they may start off with using their device and they hear it say the words for them all the time, and that's just one more model that they're hearing all the time. And so a lot of times they start to try to imitate it, and maybe they become more clear because they have a nice clear auditory model for them of what they want to say, and maybe they can attempt to say it more clearly. So we certainly do see children that become more verbal later on. Not every child will. We don't have a crystal ball, unfortunately, to know who's going to be the ones to outgrow their system and become more verbal, but we certainly see it happen. Okay, so thinking more about this, who are good AAC candidates, and kind of what are some of those basic skills that we would look for in a child to know that, yes, they're maybe ready for a device, or maybe we want to look at building some of these foundation skills before we quite make that jump. So one of them is showing interest in communicating. If we have a child that is, not showing any interest in communicating, they maybe don't have that social connection or that understanding of joint attention of I'm interested in getting things from you as a communication partner, or I'm interested in sharing something with you, my communication partner. If we don't have that yet, then those are some skills that we want to work on first in therapy before we're quite ready to maybe throw a system at them. We'll flip to the next one. Demonstrating joint attention skills. So again, kind of being able to participate in something together. Communication is a shared activity. We do it with people. And so if we don't have the concept of with people yet, we want to build that first. Having buy-in from parents. This is really key. These systems, like I said, are still pretty expensive. And there's a learning curve for parents about how to program the device, how to use the device at home, how to make sure that they can advocate for their child in the school district so that the child can have it at school, use it at school. There's a big difference between those two things. And that the teacher's involved and knows what's going on, and their school therapists, and and you guys as supporting therapies, there's a lot of things that families have to understand about AAC and have buy-in and knowledge. So some of that can take a little bit of work on the speech therapist part to do a lot of education and building of those skills in parents before maybe they're ready to take on AAC for their child. And then showing a medical need. Some of our families are very fortunate and can just go out and purchase. Maybe they can purchase an iPad with one of these apps on it. But especially for our kiddos that maybe an iPad is not the most appropriate and they need a little bit more durable or dedicated device that is going to need to be paid for by insurance, they have to show medical need. So that's usually something that the speech therapist can whip up real quick. We do a lot of these reports to show medical need, but yes, they do have to show that in order to make the case to insurance and get that covered. However, we want to say there's not really any specific requirements for AAC. Like we talked about, they don't have to be a specific age. They don't have to have a certain level of cognition. If they're showing some of those things we talked about on the last slide with, emerging communicative intent and, early social engagement, like they're ready. So that's great. They don't have to be nonverbal. Like we talked about, there are some kiddos that are very verbal communicators with a couple of, communication partners that maybe understand some of what they're saying. And so they don't have to be nonverbal by any means. They don't have to have perfect vision. Teresa alluded to earlier that there are some of the vocabulary systems and the overlay of what the screen looks like. You can switch it to be like a dark mode, basically. It looks like a dark mode. I'm sure a little bit more thought went into it than that, but they do have setups for kids with cortical visual impairment and various things like that. So they absolutely do not have to have perfect vision. Literacy level, like I said, we start off kiddos at the age of 2 with AAC, so they certainly don't need to be readers. For kiddos that are at a younger literacy level or don't have any literacy yet, they really don't need to rely on the words. They see the picture symbols or they rely on the motor plan. We do a lot of practicing in therapy of using the same words over and over in different activities so they learn where those words are. And they know, just like you know on your phone where you put your apps. You don't have to scan for it every time. You know where it is once you access it a few times, and they're the exact same way. And then symbol or picture, associating symbols to pictures or objects. This is something that we work on, so they don't have to understand that as like a prerequisite to starting AAC. That is something that we can build in as a part of the therapy when we're trialing different devices or different systems, and we can teach that as a goal as they're working through their AAC journey. And then they don't have to have experience with low tech or mid tech before going to a high tech system. Like we said before, you can start with a high tech system because a lot of those are designed to kind of be at the most basic level and then grow with the child.
So maybe now you've got a patient with one of these devices in your session. What should we do? The first thing is to be really patient. Everything is slower. So not only are they learning language, they're learning the software, families learning the software, families learning how to prompt. But there is a quote that states that an average 18-month-old has been exposed to 4,380 hours of language at the rate of 8 hours a day from birth to reach the language level that we expect at that age. And so a child who's using AAC, they need that amount of input as well, not just our 2 times per week for 20 minutes to an hour. And so they need that amount as well with these devices. So think about that. In order for them to reach that 4,380 hours, if they were only getting the speech therapy 2 times a week for that set time, it would take 84 years for them to reach that same amount of hours that a typical developing 18-month-old would have. So that just reminds us to be really patient and give these children grace, because we're asking them to do something that was already hard and now asking them to do it in an alternative way. Make sure that system is accessible at all times. They should be bringing it to other therapy sessions, to order at Sonic, to visit grandma. That should be accessible at all times. Encourage them to bring that device to your sessions as well. And then use it socially, not just for direction, not just using the device to tell them what to do in your session, but use it to greet back and forth, to talk about their day, talk about their favorite shows. And then sometimes the best way is just to offer. Sometimes silence is the best way to encourage AAC use. So we'll visit other ways to prompt AAC use throughout the rest of this presentation. But I think the main thing to take away from this slide is just giving grace and being really patient with these children.
And another kind of one of the main ways, like in a therapy session or in an interaction with a child, that we can support their using the device is what we call aided language stimulation. So those are some fancy words. Basically what that means is just modeling on the device the same thing that you would say out loud. So if I was playing with a child with bubbles and I want to encourage them to say like more or blow or bubble, and that I would say those words out loud to them and they would try to repeat them. So if it's a child that I'm hoping they will use their AAC device, then I would hit the word bubbles on the device, or I would hit the word more on there, and it would speak it, and then they would, they would have watched me do that, and maybe they would copy me and they would hit the buttons too. We're going to watch a video on the next slide that illustrates this example and the importance of what we call aided language stimulation or modeling. Okay, so what I love about that video is it shows every single person in the family is modeling on the device. And that gets us as close as we can to that 4,300 whatever number of hours that Teresa was talking about, trying to just immerse that child in AAC language learning. And so that's where you guys come in and why this presentation is so important, because they come to your sessions too. And we love when you guys can model on the device as well. Even just simple things that are involved in what your activities are. So yeah, go ahead, Teresa.
And so let's look a little bit at some other ways that you can prompt AAC use beyond aided language stimulation. And so this model is going to be a least to most model, so least support to most support. So we always start at the least. And that first one is that wait. So offer and wait, that expectant pause. You've got the device maybe on the table or on the wheelchair mount, and you're just going to say something as you usually would. What would you like to do today? And you're gonna wait and just see what they may do. Sometimes it takes them longer because they're processing the language and then they need to process where that word they're thinking of might be on their device. Next, you might use your body language. Show them that you're waiting for them to use that device. Show them that you're waiting for a response. And so that might be you're maybe throwing your hands up like in that, I don't know, a shoulder shrug, or maybe giving them that very obvious facial expression that you're waiting for their response. Next, we've got an indirect verbal prompt. That might be like your open-ended questions, where you're really opening up that opportunity, but you're not directly saying, use your device. Next, you're going to request that response. So once again, we're doing that least to most. Fourth down is where we request that response. So inviting them to use that device. Why don't you use your words? Tell me, some people call it like the talker. Use your talker. I'd love to know what you want to do today. Tell me on your device. And then gestural cues. These might be like pointing to the device, and there's different levels of pointing to the device. One is distal, where you're just pointing and referencing the device, reminding them that it's there, reminding them that, hey, you can use your device in other sessions outside of speech. You can use it outside of home. You can use it with other therapists. The other one is proximal pointing, so getting closer to that device where you might be pointing maybe on the side of the device, like the left versus right side, top versus bottom, that word might be located, and then you just work your way closer if they need additional support. They don't know where go is. You might actually get really close to that button, hover over it, or touch really close to it so they know exactly where that button might be. I think the biggest thing when it comes to prompting is we don't want to assume we know what that individual is going to say, which is why we follow this least to most approach, because we might think they want to say go, but surprise, they might say, I'm finished, or they might want to do another activity, so they'll go find car. And so we don't want to assume what they're going to say, but we do want to assume competence. So we want to assume that every person can communicate and wants to communicate. So we want to give them that opportunity, but we don't want to assume that we know what they're going to say. So that's why we want, even with gestural cues, you're going to start further out, work your way closer to the word. And then we have these partial verbal prompts, close procedure, fill in the blanks, where you might, the most common one, ready, set, and then you're waiting for them to fill in that blank, or you might be doing brown bear, I see a red bird looking at, and they'll fill it in with me. And then here we have our direct models where we're actually giving them the model that we think they might say here. So then that's a teaching opportunity. Hey, we might use the word fast here. So I'm going to model it. I go fast. And then lastly is physical assistance. This is a rather big topic because when it comes to physical assistance, we actually recommend doing hand under hand, and you are just there as physical support as opposed to actually holding their hand and forcing their hand to use the device and to use a specific word. So in actuality, that physical assistance is not a big tool that we like to lean on. We definitely don't want to do hand over hand where we are taking their hand and putting it to that device, or where you might be turning their head if they're using eye gaze towards that device. If they are deciding in that moment that is not the moment for them to communicate, then we have to honor that autonomy. Now, the hand under hand might be for our children who are learning those motor plans or who might not have the greatest access yet with that direct touch. You just gently put your hand under their hand and they are going to guide you in the direction. We're just there as support. And so some session involvement ideas, if they are in your OT or your PT or in any other session or in the classroom, is the first thing that to start with is maybe asking those caregivers at that initial evaluation, that first session, about how their child communicates to get a feel if they might have a device they just did not bring to your session. You might ask them, what do they do when they want something or when they don't want something? Like Lori said, a lot of systems, like they'll focus on that requesting piece because that gets the kid motivated and gets them going at first, but it's just as important to allow those opportunities for them to protest things because that is communication as well. Maybe you can ask the parent, how does your child give permission, especially when it comes to bodily autonomy? How do you know that it's okay that you touch them, or how they're ready to do something, or how do they make choices? These are all some great initial questions to kind of gauge how that child is communicating and if they're using a device. Encourage those families, I mentioned earlier, encourage them to bring that device to your sessions, and showing them that this device can be used across multiple environments. Another option is letting those children, like I said earlier about protesting, and letting them negate activities. Oh, do you want to do this or this? Okay, not this, or no blank. Giving them that option really opens that door for these children to really tell you, here's what I like, here's my personality, here's what is comfortable for me to do. So it opens some more doors for these children who are essentially locked in or not understood by other people in their lives. Another way to get these involved is really asking those parents to model on the device. So if you're giving some support and they're trying to work on standing, your hands are kind of busy giving some support, physical support to those children, but then those parents can model on the device too. And this is twofold. It helps the child in your sessions, it helps them learn language, and also gives parents an opportunity to really practice using that device. Offer choices, and you can offer choices using that aided language stimulation where you are finding the words on the device, saying it on the device to give them choices, and it gives them a way to kind of narrow down the language too, as opposed to an open-ended question. They could use any vocabulary, but now they've got choices and you've kind of guided them to some language that might be difficult for them to pick from anyway or navigating to. And then using it during transitions, like giving reminders, countdown with the device, 2 more minutes, then we're all done, or we're finished, time to stop, we're going to jump next. So finding those powerful words and what you're using in your transition and then modeling it on the device.
Okay. So here is the point where we want you guys to use that little question chat box thing where you can give us some feedback. So what we're going to do now is kind of take a minute to think about your therapy sessions. So you want to click once, Teresa, then okay, so let's think about a therapy session where maybe you're working on ADLs with a kid. And if you're not an OT or a PT, that's activities of daily living. So basically that encompasses a whole lot. It can be anything that you would think about, like, you know, putting on clothes or brushing teeth or, I don't know, I'm not an OT, I'm out of things. But, you know, all the things that we do every day as part of our routines, whether that's self-care or feeding routines or anything of that. So if you have a child that you are working on an activity of daily living, and they brought their device to your session, let's kind of brainstorm some words that you could model on the device during your session. So I see people popping in there already. Zip your jacket. Yeah, I need help. That's a great one. Help. Yep, just the word help by itself. Hang up your coat. Put on shoes. All done. Yep. Wash hands, those are great.
And if you need ideas, I did put the LAMP one that has a bunch of those core vocabulary words on your screen to kind of give you some guidance.
Yeah, that's a great idea, because sometimes a lot of, you know, our kiddos only have one word. And so, you know, we might be able to say, I need help, or we might just say help. Those are great examples y'all gave. Oh, I like that. Maybe starting to choose your clothing. So I want the red shirt. That's great. Yep. And we have some body parts in there with hands. Maybe you need help with your shoes. You can say feet, or, you know, even action words like push. You gotta push your foot in there. Yep, sit. Perfect. Those are all great suggestions. I love it. Okay. So we're gonna go to think of more now like a structured table activity. So, you know, in speech, we might be doing a puzzle, or I guess I'll do that in OT too, or, you know, maybe we're drawing, or we're working on handwriting, or maybe, you know, maybe we're, I don't know, really anything you can do at a table that's a little bit more structured.
I like the my turn, your turn. Yes.
Those are great. Yep, and colors. A lot of times we associate colors with table activities, with lots of materials and things that we have. Cutting, yeah. That's where the color page, at least on LAMP, the color page has all those. It's got the scissors, it's got the, you know, the action words that you need, draw and cut, and all those things. They're all there associated with art words. Two hands.
I see alphabet. One thing that's big is most of your systems are going to have a keyboard, so you can, and some of them will say the letter and some of them will pronounce the letter. It just kind of depends. Like this one, you can go into phonics and it will pronounce it as you would phonetically do it. So I think that's a great one too.
Yeah. And think about action words too. I love, it kind of lends itself to PT and OD sessions, but honestly in speech, we have to, like, I have to constantly remind myself, work on the action words, because those are harder for kids to learn, but they are so necessary in building. Once, you know, you can say all the nouns in the world, but if you don't have an action to go with it, you can't really start to build sentences yet. Give me, that's great. Clean up, copy, go, stop. Those are great. Yep. Okay, do we want to pop up the third activity idea? Is active play or motor tasks? So thinking about, you know, if you're setting up an obstacle course, or you're in the sensory gym, or you're at the playground at school, or anything like that. Yep, here come all the action words. Run, jump, fast, swing, faster. Oh, hurt. Yes. Hurt. That's a powerful
and hurt is a big one, because we get a lot of families like they can't tell me what hurts or when they're in pain. I just hear tears. And so that's a big one that we like to work on, is, you know, things that they're able to tell you, tell a medical provider what's hurt.
Yes, that's huge. I know there was a question up there. We'll get to it in just a second. Oh, I think that's a question for Allison. Okay.
I like that I need a break, especially with my eye gaze, because using your eyes to communicate can be very tiresome. And so I will put like, I need a break on the screen, so then they're able to tell whoever is with them that I have more to say. I just need a break. My eyes are tired.
Those are great. Y'all did a great job with this. I love it. Okay, so these were just some questions that we thought, you know, if a child brings their device to your session, some things that you might want to ask parents to help you either familiarize yourself with that device or to see what ways a parent can kind of help you in integrating that device into your session. So a really important one, since you guys probably won't be as familiar with the devices right away, is where is such and such word located? All of the devices have some sort of word finder. Yeah, you can go ahead and pull it up and show Teresa. Some sort of word finder feature. And so this one's on that spell and number page, a little blue icon for the keyboard, and then it's the purple button, word finder. So you just click that, you type in what word you want to find, and like on an iPad, the keyboard will pop up. So we're gonna find the word find, and then it will show you, oh, first you click the computer button, and then you click the first little green find, and then there'll be another one. So you can also click guide me, and it will just highlight it for you on this system and on many systems as well. So then you can learn where that word is and be able to actually do it and start building your own motor plan for finding that word. So if a lot of times families will add words to their devices. So for example, the child's name or things about the child or activities that they love to do that maybe didn't come pre-programmed on the device. So they'll put their favorite shows or, you know, toys that they have at home. They'll put those words on the device, and you, of course, wouldn't know where those words are unless you ask. So that's a really important question for you guys is, you know, having the family fill you in with what words are on there that are really meaningful for the child. Here's a question for a parent, maybe just asking them, what are your thoughts on bringing his device into our sessions? Maybe you know they get speech and you know they're working on it, but they haven't brought it in yet. So just kind of asking that open-ended question. This is a great like motivational interviewing question. What are your thoughts about bringing the communication device into our sessions to see like where are they? Is the family willing to do that? It can kind of maybe give you an idea of what the family's own ownership of that device is. Unfortunately, a lot of times families will, you know, be given a device and are working really hard in therapy, and then we come to find out, gosh, they're hardly using it at home, and it doesn't go out with them in the car when they go out to a restaurant, and like maybe it goes to school, but only half the time, you know. So if you're asking these questions in your sessions, that's great feedback for your speech therapist about how willing the family is to participate in it. Okay, are there any words we can practice during our session? So maybe mom just came from speech therapy and they were working on, you know, a great action word, and maybe that would be really easy to incorporate into your plan for the day. So that would just be additional carryover. So families are great resources for what words are important to the child, maybe what words are already happening in their life and come up that week. And so those are great ideas. And then like Teresa alluded to earlier, how does your child communicate with you? Especially like how would they give you permission to participate in something? How would they, you know, if I need to do some manual work on the child, how are they going to give me permission to say, yes, it's okay for you to do that work on my body, or it's okay for you to, you know, hold my legs while you're doing this, or stretch me, or, you know, how am I going to be able to say, ow, that hurts if I'm being stretched too far, you know, those sorts of things. So being able to give that child those words and asking the family how the child communicates those things to the parent at home, because then you can carry that in your session as well.
So when to refer if you have a patient that has shown those readiness that Lori talked about earlier, some other indicators that we're ready for a referral is that family has expressed concerns about the patient's lack of communication skills. So maybe they've been in speech for a while, and that's the second bullet point. They've tried the traditional speech therapy approach. There's been little progress. You kind of notice that they're getting older. Family is getting really concerned that they're not able to tell you what's hurt, what they want, tell you their favorite TV shows to a family member maybe who doesn't see them that much. That's another indicator that maybe an AAC evaluation is warranted. The patient is showing interest in sharing their thoughts. So they're with you, they're showing empathy, they're showing different communicative intents, such as they're requesting things from you, they're reaching for things, they're gazing at something for a long amount of time, and sometimes it's a guessing game to guess what exactly are you looking at. That might be a patient who would benefit from one of these devices or from AAC in general. The biggest thing is they definitely know more than they're able to say. They know they can identify different things. If you name something in the room, they can look towards it. They can follow directions really well, but they're just not able to express themselves. And when it comes to the referral process, you can talk to, if you know an SLP, if you have an SLP on site, you can speak with them, kind of give your thoughts on if that you think they might be a good one for an AAC referral. Also, just asking the physician or mentioning it to the family. Those are probably the top 3 routes to get that referral process going. Primary care physicians, a lot of them kind of have a general knowledge of AAC, but it's one chapter in a book, as opposed to an SLP sees it daily, OT and PTs, you may be having patients bringing it in. So we're here to also advocate for these patients who may be overlooked for these AAC referrals. So just to give these caregivers additional support, some of these you've heard already in this presentation. The main one is it may not be forever. It may be that stepping stone to getting them to that next way of communicating, such as spoken language, but we need this now to reduce frustration, to empower these children and these patients so that they're able to really tell us what they want, what they think. As Lori mentioned earlier, it's not going to hinder them from talking. If they could talk, they would talk. And sometimes it actually boosts their talking, that stepping stone. So that's the biggest thing we hear from caregivers and from families is, well, if we do a device, they're not going to talk. And that is, like Lori said earlier, the research is telling us that it does not. Let caregivers know that this is a way to give their child a voice, give them a way so that families can hear them ask for mom. I know that's a big deal in our sessions, is when the child can say mom. That's a big step, and I usually have a lot of happy tears in my room when that can happen. And another big thing is reminding these caregivers that trialing the different devices is so important, and it is a must. If they go into a session and they only try one system, one software, and that is the one that's determined, I think it's important to tell these caregivers, please try different devices, because it's good to have comparisons and to really get a feel on what that patient really wants to use, as opposed to, okay, this is what I see challenges in and strengths in, and so we're only going to use this system, or we're only going to use the software or the system because that is the one that this speech therapist or that professional knows. I think it's important to, if you're going to work with AAC, to really learn about all of these different systems that are out on the market, at least learning the main ones that have research behind them so that you can benefit those kids. And we like to tell caregivers that as well, that it's so important to try at least 3. A lot of insurance plans will actually require you to try 3 different programs before going towards a purchase. And to give you a little more information on a trial, it depends on the insurance plan. It could be anywhere from a 30-day trial to a 3-month trial to really get insurance to agree to paying for these devices. But the main thing is that with AAC use, we get these better communication, opportunity for these patients to really communicate so they can build stronger relationships with their family members, with their friends, and within the community. But just want to see, so we're kind of at the conclusion now. Just want to see, does anyone have any questions? Want me to pull back up any of the communication devices? Want us to dive deeper a little bit into anything? Please put your questions in the chat. And then our information is available on your screen right now, but it's also on the handouts. In case you want to reach out to us about anything, we are always happy to answer questions.
Okay, I think we were gonna, I don't know if my webcam's on. There it is.
There we go.
Yeah, I do see a couple questions coming in, so I can take the first one, which I love this question because it absolutely happens. And that is that, oh, sorry, I lost it. Hang on. Okay. That what would you do about a child who does sometimes use the device functionally, but really mostly just enjoys pressing a bunch of random buttons in a row? We absolutely see those kids. And, you know, I feel like most kids are going to go through that period of like, wow, this is a cool new thing. I just want to explore it. And so we call that exploration, and we allow for that exploration time. What's really great is if you can get a trial from insurance where they will send you the device to send home with the family. That exploration can happen a lot at home, and hopefully get some of it out of their system when they come into your session. And then you can, you know, hopefully try to gear part of your session to the functional communication. I think also what's important about that is really tapping into what the child wants to communicate, because if they find it more fun just to hit the buttons, then that's what they're going to do. Whereas if you have something, an activity that is really motivating for them to communicate about, then they might gravitate toward that. As a last resort too, there are some settings with some of the high-tech devices that we can adjust that will not make it as enjoyable for them to do that. So for example, you can change it to where when I hit the button, I have to actually hold it for like a split second before it will speak the word. And then that kind of takes all the fun out of just hitting. So there's a couple little tricks up our sleeve like that we can try, but do you have anything else to add, Teresa?
No, I mean, we kind of think of it, when I explain it to families, I kind of either explain it as babbling on the device or self-stim. And so if a child is self-stimulating with their spoken language, I kind of think of that on the device as well. So babbling, self-stim. So yeah, we want to let them do that too. And then if end all be all, we can adjust those settings if so needed. The next question we got was, do any devices cover languages other than English? Yes. A lot of these devices do come in Spanish. I've also seen it in French and then as Arabic as well. So TD Snap and Touch Chat and LAMP all come in Spanish. And they all follow the same organization and everything across all of those systems. I believe that Touch Chat might also have French, and then I'm signed up to take a course about Arabic. So they are out there. If the biggest thing that if I get a language that's not as common is I will reach out to the consultants. There's consultants and representatives for most of the major companies, and they are usually assigned to regions. And so I will find that on the website, reach out to them. And so you can do that as OTPT. Hey, I've got a family, they're using Arabic, and I think they might be an AAC person, AAC user. Does this even exist? And they're very quick to respond, almost all of them. So they're great to work with. But yes, they do cover other languages, and I'm really grateful for that.
All right, the next question is, I've worked with some SLPs who start with just a few buttons on the screen and others who believe you shouldn't limit it and should give them access to everything. Is one of these the right way? Yes, both of those are the right way. Depends on which child, depends on which, like how much time you might spend on both of those. Many children who have fewer vocabulary words, maybe understand less words, I would maybe start with just a few buttons on the screen and hide the rest. However, I would send it home as a home program for them to open it up to the full device. And like Teresa said, we call that, like, that's their babbling time. Like, they just get to explore, and you would be amazed of what buttons they find when they come in the next week and be like, look what I can say, because I figured out where this word was that I thought was really cool. So children who maybe are a little bit older or have, you know, bigger understanding of vocabulary may not need that initial period of hiding the buttons. Some can go directly to the full access. So it just depends on the child.
Cost of these devices, it can vary. So if the child may just, we already have an iPad, the family already has an iPad, and we just want to purchase an app. There are some free apps out there that don't have a lot of research behind them yet, but it's a start. It's better than nothing. When you go towards those dedicated devices, you're looking at a couple $1,000s. So anywhere from $3,000 and up. When you were looking at eye gaze and mounting, we're looking at, I believe they start at $7,000 because that's the device, the eye gaze system, and then they also have to add on the mounts on there as well, which is why in those cases, we really encourage families to try to go through their insurance plan so they at least get some, if not all of it covered.
Let's see, what app would be best to use for visually impaired and toddlers who are verbal but struggle with producing certain speech sounds? I feel like there's a lot of options there. With visual impairments, I know that the print key, Romic, so PRC, Saltillo apps, now not their apps, so not just like I can't just pick up an iPad and go to the App Store and download that and have the visually impaired side of that. But if you get their dedicated devices, they do come included with the vocabulary sets that are color matched or color coded for visually impaired and have those settings on there. So that would be my first thought, is to go through more of a dedicated device for a child like that. Toddlers who are, oh, go ahead.
And I'm going to pull up while Lori's answering this question what a visual impairment board might look like, so y'all are able to see the difference visually. So I've got to work on that.
Okay. And then toddlers who are verbal but struggle with producing certain speech sounds. So for that, again, I think it would depend. Like, I struggle to say, like, would that therapist their speech therapist be working on, like, maybe they have an apraxia and they're working on speech intelligibility at the same time that they're working on like supporting their verbal communication with a communication device. I don't think there's a particular app that I would suggest for that, because I feel like those are two separate goals, kind of plans of care. So I'm not sure how to answer. There's not an app that will facilitate certain speech sounds. It's going to be a robust vocabulary system that you could teach the child, and then they would use that in support of their verbal communication when their verbal communication breaks down. I hope I answered your question.
So I kind of threw up on the screen, this is the lamp for visual impairment, and it has the high contrast, so black background with high contrast colors, and they are also specific colors that they have found in research will stand out more, especially with our CVI or cortical visual impairment children. So this is just a chance for y'all to see that. I also was able to download the TD Snap one, so y'all are able to see that. The question was the organization earlier. Here's the main difference is right here, you have some quick fires. So that just means like things we might commonly say, so they can just go into that folder, one major difference. And then as well as like here, all the descriptors are all in one place, as opposed to on LAMP, you kind of saw little is right here, right there on the page, but big is located over here. So.
Okay. The next question, I have a 2-year-old that's not strong enough to push the screen. I've been brainstorming with the speech therapist. He also has difficulty isolating a finger, and we tried a sleeve that allows one finger out. What a great idea. But that didn't work, unfortunately. I'm curious about your comment about being strong enough to push. So all these high-tech devices are touch screens. So just like your phone, you would, just the simple contact with the screen should activate the button. So I'm wondering if maybe, so if you guys remember back to the mid-tech slide where I had the pictures of just the single buttons, and then there was that one with the 4 squares, a device like that you would have to actually push in. And so I'm wondering if that is maybe what the difference is. But if that's the case, yes, isolating a finger is certainly a challenge. So there are styluses out there. So you could do something like it has a grip and then there's a stylus on the end, so they could hold it either like this or however which way they hold it. You could get someone to 3D print something for you that worked, or a casting with casting materials, kind of create something that they could grip in however what way they can grip, and add a stylus to it so that then they could touch on the screen. What other ideas have you tried, Teresa?
So I'm thinking like a key guard or a touch guide, because then if they don't have the strength, like I wonder, is it like coming from not just like their hand, but like if they could get on the key guard and like rest here and then push, that might give them just additional support just to get that button activated. And then I would just double check like on that device, whatever screen you might be using, make sure it's on its most sensitive setting. I know some systems come at a general setting, but you can adjust it in both directions. So that would be something I would just consider as well.
I'm going to throw my 2 cents in here as the OT and the not just the moderator and the OT, but we do have a product called the Functional Hand, which would hold that stylus. And for those kiddos, we would add an easy hold on top. And so that person who asked the question, if you have any questions about that, send an email to Allison@therapro.com, and I'll happy to hook you up. But these are the kiddos that I worked with in my previous life. So Functional Hand with an easy hold was how we would modify that.
Yeah,
I do see you kind of gave us some more feedback. He has the screen without dividers, very, very low cognitively, and couldn't do a stylus. So yeah, maybe thinking really outside the box, like with that product. But yeah, I'm thinking key guard or like a touch guide, just to see if maybe he can rest and then push. But yeah, if we're looking at low cognitively, another option would be to kind of have larger buttons, so then he doesn't have to like aim as specifically. Other options we can look, I would say, like looking at other access points, like a switch maybe, and seeing what maybe extremity maybe he has more strength with. That might be an option as well.
And cognitively, I was going to say, cognitively, if he can't make a choice or understand a choice yet, just starting with a single button, like a Big Mac button, could be just an easy way to teach like cause and effect. I hit the button and here's the result I get.
Mm-hmm. And then it looks like we have one more question about eye gaze as a means of communication. I love working with children who use eye gaze because they're usually my older patients. So they usually have sassiness and a lot of quirk that they want to share. And I love getting them to the point of sarcasm. I absolutely love that. So when it comes to eye gaze, it is like the dedicated device, so a tablet, and at the bottom of it is a bar that uses light to follow usually like their pupils and where it's moving. So you do have to calibrate. It's a little more tech involved. Calibrate it for the patient so that it's able to follow. Now, there are even times where we only need to calibrate one eye because maybe the patient has one eye that they can track better with. And so what they'll do, they'll use just like the systems we showed today, that lamp, the TD snap, they will use that exact same system and will have like a hand cursor, an arrow, or the square will light up, so then they know exactly where they're looking. And we usually give it a little dwell time, so they dwell on it for maybe half a second, and then it activates the word. I feel like I could go on about eye gaze, but I feel like that kind of hits it in a nutshell. They use the exact same systems, they just have an additional accessory, and it's calibrated to their eyes.
And then another question here, how would you introduce switches to a toddler who's confined to a wheelchair and they may want to put the cord to the switch in their mouth? So our equipment reps are really good at all the things we can do to the wheelchair to kind of safeguard everything that's attached to it. So there are different mounts that you could mount the switch as well, and then make the cord, you know, inaccessible to the child. I would say for the most part, the switch would not be kind of free floating where the cord is just kind of out there. For the most part, you're going to want to have it in a place that's where it's mounted or attached to, like if it's a tabletop or something, you're going to have it kind of sitting there, you know, not just sitting on the table, but attached with Velcro or something like that, to where, you know, it's not something that they can just grab and go with it. So there are lots of different ways, kind of depending on what their setup is, that you could maneuver that a little bit.
They also make Bluetooth switches now. So if they are using a dedicated device, they can connect with Bluetooth, and that way you have no wires. There's also like little sleeves that go around the switch if you're using like a head mount one, or something that has an arm on it with all the cords hanging off, because that's fun to play with. They can put a sleeve on that, so that hides those cords a little bit more as well.